Let me just do a little brief introduction for Dr. Foa. Dr. Foa's lifetime of dedication to effective treatments for folks with PTSD as well as other anxiety disorders has been recognized around the world. She's received several Lifetime Achievement Awards from the American Psychological Association, the Association for the Advancement of Behavior Therapy, the International Society for Traumatic Stress Studies, among many others. She's authored hundreds of journal articles and books and chapters, and was named one of Time Magazine's 100 most influential people in the world for 2010 as one of the great thinkers of 2010. And these few lines of introduction barely scratch the surface, really, of all of Dr. Foa's many accomplishments. But we're really overjoyed and happy to be here with you for this informal kind of Q&A. So as I mentioned, we did receive some questions via email that folks were interested in. But again, if there are any questions that you have as we go through or that are coming to mind now, please feel free to go ahead and write them in the chat. And I'll let Dr. Foa say hello as well.
Hello, everybody. This is an exciting opportunity for me to be unprepared, as I usually am, by giving lectures, workshops, etc. I'm here with no preparation and eager to answer questions. And maybe there would be questions that I wouldn't be able to answer. And then I would just, share it with you that I don't have an answer. But hopefully I will, have an answer to some of your questions. And I enjoyed this opportunity to just kind of be thinking together with you.
Yeah, great. And we did receive a number of questions. I received a number of questions via email. So as you guys are putting thoughts together and, like I said, if you want to put any questions in the chat, go ahead. I can start with some of those questions that I've put them in a list for myself in no particular order. But here's one that came in. I don't know if this will be difficult or easy to answer. How did you come up with the idea of prolonged exposure for PTSD?
Well, it was 1980 when PTSD was introduced into the DSM. So we actually, beforehand, PTSD was called combat shock and all, there were many names for it and no treatment. Actually, there was a treatment that was developed in World War II. And it was really to put patients on barbiturates, get them kind of go into the traumatic event, into combat, and then react the programs with noises from the programs and with kind of pretend or make pretend that the person is back in combat. And that treatment was actually not very helpful. Other than that, we didn't have treatment, but that was not PTSD. That was treatment for combat reaction. So what do we do when we have a new disorder in the DSM and no treatment? Well, I thought, well, maybe PTSD is like phobia. Now, I did work with phobias, and I already was, I don't know that I was an expert on phobias, but I had a lot of patients who were phobic. And and I thought, well, maybe this is some kind of a phobia. I also had several rape victims that I treated. And I thought, well, now that I think about them and in retrospect, these people, and I had 2 or 3 or maybe 4 combat veterans that came with nightmares and flashbacks and things that we did not have a name then. And I thought, well, oh, maybe that PTSD is like phobia. So I will take the treatment that we do for phobias, which is in vivo exposure. What is in vivo exposure? We used to make a list of situations that a person was afraid of. Let's say dogs. Person is phobic for dogs. We take a little dog, we put him far away in the room with the patient, and a sweet little dog. And then we brought a dog that was a little larger, and then one that was really large, gradually. And we had treatments, and the treatment we have for this in vivo exposure was very successful with phobias. And you could even have 1 3-hour session, and you would cure a phobia. Well, I thought, okay, so if it is some kind of phobia, we need in vivo exposure. But then when I was thinking about my patient, the rape victims and the combat people that came, I said, well, it was much more complicated. So what else do I need? Well, all of them, I felt had traumatic event. Not all phobias, even dog phobias, only 50% of them had some kind of negative interaction with dogs. With PTSD, everyone had to have a trauma, and that was in the DSM. So you have to have a trauma. So what do you do with the trauma? I know what you do with with people after their phobia, they avoid. I know how to help them not avoid, but that's maybe not enough. So then I thought, well, we need to somehow process the trauma, so the trauma will not haunt them. So I said, well, we don't want to do the abreaction like they did in World War II. This was absolutely like no barbiturates, not putting the patient exactly into the trauma in their imagination, but something that would be much less harsh, but yet would allow them to process and digest the traumatic event. So I thought, okay, well, let's try. And it was all trial and error because there was no treatment really for PTSD. Let's try to ask them to recount, to revisit the trauma. But we told them that they're here with us. We didn't try to get them totally into the event itself, so that you would be so scared that, that it will actually can harm them. And so we were sitting with them very quietly, and we said, just tell us what happened, as much as you remember, with a pleasant tone of voice that as a therapist, not a scary voice, like they used to do in the abreaction, like screaming and yelling. A therapist. I saw a movie that showed me how it was done, and I said, "Oh my God, I would never do it." So, and then they would tell the story, of their trauma. And one time, I realized it's not enough. And so we did it, kind of in one session. They were more anxious gradually. It was, and I kind of thought it was like, like a book. Like you have a book in your brain. And, in the book, it's like the book of the trauma. And the book opens, and you are telling what happened in the book. And when patients were crying, they were upset, I thought it's important to tell them you're doing okay, to intervene and say you're doing okay, you're doing really fine, keep on, and encouraging them. So we call that emotional exposure. But then later on, actually, we find that after the imaginary exposure, we need to do something in addition. And then we said, after they were in this memory and revisiting the memory, we need to ask them how they felt. What did they learn from it? And we called it processing. And that came a little later, maybe 3 or 4 years later, that I realized that, we need some closure, on the story. So how did you learn? What did you learn? How was it difficult? How did you feel? And also giving them compliments. You see, you can do it, and you didn't fall apart. And, so you are stronger than you think. So building the ego at the same time was this part of PE. Part of PE is, we ask them to do things that they don't like to do because we know that PTSD patients are avoiders. They don't want to go to places that remind them of the trauma, and they don't want to think about the trauma. And that's what maintained the PTSD. And so we developed a treatment that would not allow them to not avoid thinking, not avoid situations, process it all, right? And then we find out the first study we did was 9 sessions twice a week. And we saw that 80% of the patient, 85% of the patient did well. I'm not saying that all of them didn't have a symptom of PTSD, but 80% did not meet the criteria for PTSD anymore. And even the 20%, the majority did somewhat better. And we know, there is no treatment that is good 100%. Not a physical treatment and not a psychological treatment. So 80% I thought was fine. And then that's how, and then we did a lot of studies. We did several, and then we disseminated in the world. And in the beginning, we actually have, the manual was 5 pages. Why? Because it was done only in our place. I was there to supervise. So we didn't need a big manual. Once we decided to disseminate it to other places, we wrote the manual thing. And And now, and gradually, people in Australia, people in Holland, people in Sweden, all, did studies, thinking and thinking, because if I am successful with the treatment that I invented, maybe I'm biased. But then other people that they didn't have any interest in showing that PE works found the same results. So that's how I developed, and it was in stages.
It's really amazing to think about how it really was trial and error. Something that we see now as, a protocol was really just let's see what happens and see what works. So that's amazing. Thank you for that. Another question that we have here is, I think this is an interesting one. Who is or was your role model in the field?
Well, it's difficult to say because, my first job in life was with Wolpe, Joseph Wolpe, who was like the father of behavioral therapy. So he influenced the in vivo exposure part, because that's what we were doing with him. But the person that influenced me more, it kind of the theoretical point, because I came from a theory. I didn't just came from trial and error. I had in mind what needs to be done. What are the mechanisms that needs to be done in order for PTSD patients to recover? And it was Peter Lang that really influenced me. He became a friend, a very personal friend, and also, I never worked with him, but he was also my intellectual mentor in that area. And Peter Lang came with the idea that if you want to cure a phobia, remember that was all before PTSD, 1976, before PTSD was in. So he was talking about phobia. And he said, in order to cure phobia, you have to ask the patient, and he actually said in imagination, not in vivo, you have to ask the patient to imagine what they're afraid of, like the dog. It's the field stimuli. And then if you only presented the field stimuli, you didn't get that good result. So it came with the idea that you need to imagine not only the field stimuli, the dog, but also your reaction, your responses to the dog, like, heart rate beating fast, running away, hiding under the table. Anything that had happened, in the trauma, to get it involved, both the stimuli, the dog, and both what your responses was. And then you get much better result. We then added the meaning. And that was my addition, that it's not enough to do just the dog and just the heart rate beat, but also what's the meaning? And the meaning of a dog is biting, danger. The meaning of the response is, I'm afraid. Yeah. My heart is beating, I'm under the table, I'm running away because I'm afraid. And the meaning is very important because you can have the same response when you run. Your heart is beating fast, you are running, and that you wouldn't say that you are afraid. You wouldn't interpret it as a fear. You interpret it as I'm doing a good job, working out. Right? So the meaning is, also that was, my contribution to the theory. But he was extremely influential on my thinking, not necessarily on the treatment, but on the thinking about the treatment.
And I would say much less well known than Wolpe too. So you don't hear about him very much in, psychology classes.
Well, not anymore,
Yeah.
but you used to.
All right. Another question that we got was, what do you think are the biggest misconceptions about prolonged exposure?
Well, I think the biggest misconception is that prolonged exposure is dangerous, that it can get people worse. And it's true that therapies are, not anymore, but it, less and less so. We have now over 100 studies. The studies that are, controlled studies showing that PE works. We had only one study that showed that 3 people got worse. And then the way that the study was done was, I wouldn't do the treatment like this. I mean, they put electrodes on the person because they were more interested in the research than in curing the patient. And then even in that study, at follow-up, everybody got better. The people that were worse tend to get better. So that's a misconception that I faced very much in the beginning. We don't face it anymore.
Yeah, definitely. The tide has turned a little bit because of all of that research that you're mentioning. Yeah. All right. We have a question about what do you think sets PE apart from other evidence-based treatments?
Well, other evidence, let's take CPT, cognitive processing therapy. It's done, or CBT, I mean, like cognitive therapy, like back cognitive therapy. First of all, it's all done with the therapist in the office. And there is a lot of, the treatment includes a lot of forms that the patient has to complete. Like, what's the probability that if you go to the supermarket, you're going to be shot to death? Have you ever heard about a person that was shot to death? And it's all very rational. It's a kind of treatment that I think was produced for middle class, in people, with high education. Because, we are seeing a lot of patients, especially in University of Pennsylvania, where it is in the inner city. And we see a lot of people from the inner city, and they don't talk this rational talk. That's not the way they think about the world. And it's nothing wrong with it. It's just that they don't think about probabilities and about chances, and all of that. And so in PE, you really don't have to have a lot of knowledge to do PE, or a lot of way of thinking rationally, because everybody that has legs can go to places and do in vivo exposure if they want to. And they can if they want. Everybody that has a tongue can tell a story of what happened to them when they had a traumatic event. Some people are more kind of affluent about it. Some people tell it more detail, some people in less detail, but everybody can tell you, if they want to, what happened to them when they were raped, what happened to them when they were in combat and their best friend were killed in front of their eyes. They can tell you. So you don't need to have a special knowledge or a special skill in order to do PE. And I also think more and more lately that PE is a storytelling. And ancient cultures and African cultures in Africa, cultures that are built on storytelling. So they sit and they tell the story of their life. And they tell it to, the special wise person if they are disturbed or they are sad or they are depressed or they are anxious. They go to the wise person and they talk to him, they tell the story, they tell what happened to them. And the PE, can be looked at as a variation, as a Western variation of storytelling. So in that way, and I actually don't like that everything is done in the office, and I don't like forms. I think that it's just having this form, what is the probability? And do you change, what do you think now after we talk? Do you change your probabilities? Right? And that requires a certain culture that thinks like this.
Yeah, I think that's a great way to think about it, because there are so many, evidence-based treatments. Not so many, but there are a handful of evidence-based treatments for PTSD. So it's good to look at what are the differences between them.
And I, as a person, like action.
Mm-hmm.
And so, go give a homework, go and do, and gradually, we really don't want to frighten our patient, and we don't want our patient to suffer unnecessarily. But, just like if you broke a leg, you need to do surgery. You go and you do surgery, and the surgeon doesn't ask you if you like it or not, and and it doesn't promise you there is not going to be any pain. And you go, and if you want not to limp, then you go and do the surgery, right? Well, it's the same here. This is not a surgery. It's just, a metaphor. Right? But here, yes, people do get up, people, they are avoiders. Right? They do get upset when they go, when they tell the story, the first time, the second time, maybe the third time, and then they start to get used to it. And it doesn't upset them as much. And at the end, many times they said, I'm so bored. Yeah, just, I'm done.
It's so true. Yeah. We had a question come in about what to do or how to work with clients that want to drop out of PE before their sessions are complete. Any advice?
Yeah. Well, if the question is, they get upset, And, and then they said, I don't want to do it anymore. And so if the patient, you don't fight with the patient. There is one rule: don't fight and don't argue with the patient. And don't, you can then sit with them quietly, and we discuss with them the reasons they came for treatment. And we discuss with them, you have avoided all these years. Yeah. You say to yourself, I want to go to this place because it makes me sad, it makes me miserable, it makes me anxious. So I'm not going to go. I'm not going to think about the trauma. I'm pushing it away from my mind because it's painful. And what happens? Here you are 10 years later, and you have PTSD. So you came to treatment because, remember, tell me why you came for treatment. What is it you want to achieve in 3 months from now? Because remember that PE is up to 15 sessions for the most part. Very rarely do we give more than 15 sessions. We're talking about a treatment of 3 months. And so we ask the patient, what do you want to achieve? When in 2 months from now, in 3 months from now. What's your goals? Well, I want to go back to be with my friends. I want to go to the movies with my wife. She's nagging me all the time. We don't do anything. I want to go to restaurants. I haven't been in a restaurant for 20 years. I'd like to do what other people are doing. I like to do what I used to do before I had the trauma. Okay, then as we know, avoidance keeps the symptoms of PTSD alive. So what do you think we need to do in order for you to get you much better so you can go to a restaurant, so you can go to movie, so you can go to bars, so you can do the thing you used to do before the time. So, maybe I was too difficult with you let's take something a little easier. Right? I take the responsibility on me. I'm the therapist, I should know. Let's take, maybe I made a mistake, maybe I rushed too quickly. So let's take something that you and I agree you can do. So that's the way I deal with patients that are saying, I don't want to do it anymore. What are you paying? What's the price you're paying for not doing it anymore?
Yeah, great advice. Thank you. Another question that we have here is, what do you think is the single most important thing to know about PE or about PTSD?
Well, the single most important thing to know about PTSD is that PTSD is maintained by avoidance. Right? And then if that's the case, you need to do exposure. You need to teach the person not to avoid. So that's about PTSD. About the treatment, I think we do have studies. The first thing you need to know is that when you do the in vivo exposure or the imaginary exposure, it has to be exactly about the things that the person is afraid of. Like, for example, if a person comes to the therapist and said, I'm not afraid about small dogs at all. Chihuahuas don't bother me. But medium-sized dog and big dog, I'm terrified. Well, the therapist goes and he couldn't find a big dog, so he brings a Chihuahua. And the patient said, why are you bringing chihuahuas? I told you I'm not afraid of chihuahua. So the first thing that is important is that during the exposure, either the imaginal or in vivo, it has to be about something that the person, it has to match the fear and of the patient, what the patient is afraid of. And it's not just fear, guilt, or other emotion. It has to do with matching the emotion that the person has. So that's the first. Otherwise, there is no what we call activation. It's like the guy that said, so what, why do you in 2 hours? I don't, that doesn't bother me. So, if we ask a patient with PTSD to talk about, what happened to them yesterday that they didn't like so much. But that's not what they're afraid of. That's not what drives the PTSD. That wouldn't work. Even if you ask the patient with PTSD, why don't you imagine a big lion? But they're not afraid of lions. They're afraid of driving on a highway. So, it has to be matching of what the patient is afraid of. That's number one. Number two, you have to have in the situation a corrective experience. So I would not send a rape victim to a place, dangerous place, in the middle of the night, a place that she can be raped again. Because I'll send her to a place which I know is nothing is 100% safe, but 99.9% safe. And maybe I'll send her first, with a friend or with a relative. And then the next time, the person will go by themselves. A coffee house. They're afraid of dark. Coffee house in a safe neighborhood, and sitting there at 8 o'clock in the evening and drinking coffee and have a cake. So then they see that it's not dangerous to be by yourself in dark. So there are two. The thing to repeat is you have to have a matching, that the situation matches the fear, and it has to be a corrective information that nothing bad will happens in the situation that you were afraid of. Nothing bad happened. Nothing good can happen.
Yeah, that's great. Really important to keep those things in mind. Thank you. Here's an interesting question. If you never studied psychology, what other profession do you think you would have gotten into?
Oh, well. So when I was 14, I wanted to be a historian. History of Europe and history of America. And that lasted for about 2 years. And I went at 16. Well, I was born in Israel, and there is a lot of antiquities in Israel, an old country. The oldest place in Israel is 9,000 years BC, before era. And so Israel, Jerusalem is full of antiquities. So then I decided I would be an archaeologist. But that was all in high school. When I got to college, I had an excellent teacher in psychology. And he really influenced my decision. And then I became a psychologist.
And thank goodness, because of all the amazing things that you've done.
Thank you.
Yeah, that's
Maybe I would be inventing archaeology things about
true.
archaeology. You never know.
Yeah. Okay, another question. Has anything about PE, research, effectiveness, public opinion surprised or shocked you?
No, I don't think anything shocked me. But there were studies on phobias before 1980 that showed that longer exposures in imagination, like exposure, like think about your rape, think about your best friend that was killed. Longer exposures were much more effective than shorter exposures. So it was like 10 minutes versus 40 minutes. So the 40 minutes was much more effective as a treatment than the 10 minutes. So I thought that in the imaginary exposure that we will do for PTSD, you need to have longer time in order to it to work. So we started with 1 hour and sometimes 1.5 hours of just telling the whole story from the beginning to the end. Well, then we thought, well, maybe you don't need, let's do it 1 hour. But then, in 1 hour, you couldn't have asking for homework, give homework, ask how you're doing, and explain the rationale for why we are doing what we're doing. And patient want to ask questions. So, we did it for 1.5 hours. And that became a barrier because in most places, in most systems, you don't have 1.5 hours of psychological treatment. And so it was a barrier to dissemination. And, some people were unable to do the PE because they didn't get permission to do 1.5 hour sessions. So then we did 2 studies that one small, and then the next one was 160 people, large study. And we compared 20 minutes of imaginary exposure to 40 minutes of imaginary exposure. And lo and behold, what we found is there was no difference in the effectiveness. So now, you could do PE in total of 1 hour, and it's as successful as you've done it in 1.5 hours. So that was a great barrier for people to actually adopt PE in the military, in the VA, in private practice. I mean, you could give 1.5 hours, but most of the time you will do 50 minutes or an hour, right? Or if you are working in the VA, they won't let you do 1.5. So that was a great barrier. We solved it with research.
And it is surprising, I think, to many people that the shorter imaginal exposures can be just as effective without adding more sessions on. So it's great that that question was addressed. You mentioned dissemination a couple of times. We actually have a question about what do you think have been the biggest challenges in disseminating PE globally?
Well, I think the 1.5 hours was the biggest, really was the biggest challenge. And in general, Dissemination is difficult. Okay? Any dissemination is difficult. Dissemination of medications are difficult. I mean, there is a whole science of how to convince doctors to start giving the patient new medication. And also, drug companies are bribing doctors, so they would try to their new medication. So dissemination is difficult. People are used to doing what they're doing, and they don't want to change. So, I mean, psychologists, are used to do counseling, supportive counseling, psychoanalysis, any kind of psychotherapy or talk psychotherapy. They are not used to give instructions. This is your homework. You have to go to, Broad Street at 7 o'clock in the evening, and there is a coffee house there, and you sit in the coffee house at least half an hour. But even if you sit 3/4 of an hour, it's better, so you can find out that nothing bad happened to you after dark. Well, I mean, therapy, it's hard work. It's hard work to think, how am I going to get this better in 15 hours, not in 2 years, not in 3 years. So that is, people are still a dynamic psychotherapy, ask about your past and your grandparents and your parents and how bad they were to you and what kind of things happened to you, and, talking about it. And in fact, they are used to the patient having the agenda. So you patient come and said, how was your week? And if they have if they are lucky, they have a patient that is talkative and tells them, oh, it was horrible. And I quarreled with my wife, my children was terrible. I had to go to the principal because, my 15-year-old, misbehaved in school. It was a very bad week for me. And then you say, well, tell me more about it. And, and that's the therapy. PE requires a lot of effort that that you want in 15 sessions and even less. I mean, many of our patients do only 8 sessions or 9 sessions. So 15 is kind of like the maximum. And you want to see evidence. You want to see progress, not in 2 years, in 3 months. And that is a barrier for therapists who grew up on the idea that therapy is years. Yeah. And therapy should be in depth about the personality of the person, about what kind of, how did he grow up, what kind of upbringing they have, how much they hate their parents, and so on and so forth. And that's more interesting to psychologists. I mean, PE is not that interesting. If you want to, kind of know about the patient and who is the patient and what's their life and their relationship, there is no place for it. It's very kind of dry and to the point. It's a little bit like doctors, really. I mean, they don't go into your life. They ask you about the symptoms and they give you a medication. We ask about the symptoms and we have a treatment for it. For the symptoms, not for the whole life of the person. And some people don't like it.
Although I would say too that the reinforcement that we get as therapists from seeing people get better in that short amount of time far outweighs some of what might be considered less appealing to the dryness of things.
It has changed.
Yeah.
Over the years, it has changed. But this is a barrier also that cognitive therapy has, because cognitive therapy is also not years and years and years. Okay. So, all the evidence-based treatment are kind of short term. And they are not in depth about the personality of them, about their, life experience and so on.
Another question that we had come in, again, I think all these questions are interesting, but this one's interesting. What advice would you give to a newly trained PE therapist?
Two, that comes into my mind. Well, that needs a little thought. Well, we know that PTSD always has comorbidity. I mean, I never saw a patient with PTSD without either depression. It can be OCD. It can be, borderline personality. It can be a lot of things. And so with a new patient, I would try to find a PTSD patient that is not so complex. That's the first thing. And the second thing, I think, that what I would like to do is to advise the person that just started to be in supervision. Because we did do a very large study in the Army, and we find out that the people, and we had half the therapists, they were all therapists that didn't know how to do PE. They get a 4-day workshop, and then they half got supervision and half didn't. And the people that got supervision did the treatment better. They had better results with the patient. The PE was more effective in their hands. So I think that taking supervision with your first and second patient it would be very helpful. I know people who've done it without supervision, but I think supervision will help the therapist had good achievement with the first and the second. And if you don't get, all of us get failures. All of us get patients that didn't do so well. But if your first two patients are not doing well, then you may get kind of disappointed and decide, well, this treatment is not for me. Or maybe I'm not good enough for this treatment. So, and then you give up. So I think that, being even don't have to have individual supervision, you can have group supervision. Then, five, like in fives, and then you can bring your case, and maybe it's 2-hour supervision for 5, people, and you present your case, and you get advice. And the probability that you are going to do well is greater if you get supervision, as we know from the study that I did, and from everyday life that we see. Yeah. And to not take a very complex patient.
I think that supervision helps with getting some people over the, potential fear of doing PE themselves for some new therapist. It just helps to have that safety net. So that's great advice. Okay, we only have about 3 minutes left, and there's a bunch more questions. Maybe I will put one more question out there. Why do you think PE is so effective? Broad question.
Well, I think because, from the theoretical point of view, you start with Lang and you go on, you actually address, what the patient needs. So remember that not every patient has PTSD. The majority of patients, they have symptoms immediately after a traumatic event. And for the majority of them, actually, they don't forget about the traumatic event, but they go back to everyday life. They function, and they don't suffer all the time. They don't feel distressed all the time. So it's a minority of patients, of people that get actually PTSD, and that's because of the avoidance, right? So PE addresses it. Okay? PE directly addresses, not in a roundabout way like CPT or CT, not, it addresses, with the in vivo exposure, it addresses the fear and avoidance of places and situations in the world. With the imaginary exposure, it addresses the avoidance of, it's painful to think about my rape. Obviously, it's painful. But it addresses the lack of closure that people that avoid don't achieve. And then the processing helps them kind of realize more, how they can change, their view about the world. The world is sometimes dangerous, but most of the time it's not for most people. And they feel they are incompetent, people with PTSD. And then, they go to places, they do the imaginary exposure, they see they're not falling apart, and they see they can do it, they feel good about themselves, they feel more competent. Okay? So with the way that, and that PE addresses, all the mistakes that the person do, all the things that maintain the PTSD. That's, I think, why PE is so, and is so effective. But also, as I said to the first question, I think it was the first question, that you don't have to be very smart. You don't have to, be very kind of intelligent, intellectual. You don't have to think, like in a rational way. Right? You have to have legs, you have to have tongue, and you have to have a wish to get better and to follow instructions. So the simplicity of it, makes it more successful and easier to learn. I asked Beck, who invented cognitive therapy, how long should a person learn cognitive therapy until they're good? And he said 2 years. Well, we have patients, we have therapists learn it in 4 days, plus I would like them to be supervised for 2 cases.
Makes a whole lot of sense. Well, thank you so much, Dr. Foa, for answering these questions. It's
It was
been
a lot of fun.
here. Yeah. So thank you, everyone. Thanks, Dr. Foa. And
Well, you're welcome, and thank you for being here with me. And
thanks,
thanks,
everybody.
Sandy, for being such a good moderator.
Thank you. All right, guys, have a good rest of your day. Bye-bye.
Bye.